Hi everyone, I'm Aimee Robson. I'm the Deputy Director of Personalised Care at NHS England. I'm a physiotherapist by clinical profession and working in this strategy and non-clinical role in NHS England nationally. I'm delighted to join you today for Health Careers Live and talking today about the transformative value of personalised care for our NHS people and the populations that we serve. Firstly, it does go without saying that if we look after our staff, they will look after our customers. In the NHS health and care setting, our customers are broadly our people, but also our broader tax-paying constituents. And it's really that simple, just as Richard Branson says. This message comes very timely with the publication last Friday of the NHS Long-Term Workforce Plan, which was published last week, which has some key messages about retention of the workforce and the value that they add. Some key messages from the NHS long-term workforce plan include recruitment of growing the workforce, retaining existing talent, reform in terms of how we work, but also how we train, to train differently. And these key messages you will hear throughout the NHS 75 celebrations and are really relevant because personalised care plays a key role in all of these elements of recruit, retain and reform the way in which our workforce lives, breathes and functions. And this plan sets out this intention over the next 15 years and key actions to address them. So how will we spend the time today? First, I'm going to talk a bit about what is personalised care and so what? Why does that matter? And then next, talk a little bit about how personalised care helps our health and care workforce in terms of establishment and skill mix, learning and development, culture, and help improve some key system problems in the health and care workforce. Ultimately, what this means is taking a what matters to you approach at a person level, at the individual clinician to patient dynamic, but also at a more meso and macro level within the health and care system. And this helps us to really achieve the quadruple aims of healthcare improvement, which is what we should all be striving to achieve to optimize the care for our populations. Starting in the top left, we really want to optimize the health of the population and health equity. To the top right, optimize experience and outcomes for patients and service users, including our carers. At the bottom, the health and well-being of those who provide support and support care are essential. And this includes the wraparound organizational development elements to support our workforce to thrive. And then lastly, if we get all of this right, we get good use of resources as an output of doing all of those other things, looking at our population, triangulating that with the outcomes of care, looking after our people, and we get the best use of resources. This is what we're trying to strive to do. And personalised care plays a key role in all of these elements to truly deliver that quadruple aim at a patient level and at a population level. And really, this aligns very strongly with the messages from the long-term workforce plan of grow the workforce, retain existing talent, work and train differently, and building flexible teams. So these are some questions that we'll ponder today. So what is personalised care and so what? What difference does it make? Isn't this happening everywhere in England at the moment? Let's contemplate and review what the data shows us. For me, my definition of personalised care is reflecting on it on a continuum of paternalism on the left and consumerism on the right. Paternalism being where the health and care system or a clinician decides what the person needs and they receive it. And the opposite being the patient decides what they need for their care, even if it's not safe or effective for their care. To me, personalised care is both the middle of that continuum, as well as the ability to meet the person where they are in that moment of time and slide along that continuum. Really, to do that, we have to recognise and support the autonomy of the person, support them to make decisions, truly implement evidence-based medicine, and take a health coaching style of approach. But to do this doesn't happen by accident. It requires knowledge, skills, and confidence, as well as the culture, the infrastructure, and the ethos of the health and care ecosystem to be able to support the workforce to be able to operate in this way, not only with skill, but also with their surroundings. There are 6 component elements of personalised care when we speak about it in policy. Starting at the top, there's shared decision-making, the construct of how clinicians have conversations with patients about what matters to them, taking into account the options, choices, and co-designing decisions about their care with the patient. Enabling a legal right to choice, including choice of provider, is essential. Going to the bottom left, personalized care and support planning helps people primarily living with multiple long-term conditions where they require proactive approaches to address their long-term care plan needs, and means that care is less reactive and more proactive and planned in a way around what matters to the individual and their support system around them. Bottom middle is a health coaching and supported self-management. These principles of how we consult with patients help to build an individual's knowledge, skills, and confidence, empower them to play an active role within their care, and happen through evidence-based constructs of health coaching in practice. Social prescribing in the bottom right helps to connect people with community-based assets and helps really connect them with clinical and non-clinical services to support them in their holistic needs. We know that 20% of patients showing up for general practice do present with non-clinical needs, including housing or finance-related matters, and connecting people with social prescribing can help bring in varying voluntary sector organizations to help support them in their wider determinants of health. And then in the top left, we have personal health budgets, which really help a person in specific circumstances to manage their own financial budget, having ultimate choice and control about how they execute their care. These are most evidence-based in more complex mental or physical health conditions and manifest in a number of ways through legal mechanisms in integrated care boards. So when we talk about personalized care in a policy sense, we mean these 6 elemental components. When we talk about it in a clinical sense, we think a bit about moving along that continuum between paternalism and consumerism. And again, to do that, it's about meeting the person where they are at that moment in time and offering the options of what's available for them and what matters to them. And looking at this in a slightly different way, we acknowledge that there are elements of the whole population should have access to those elements of personalized care. People living with long-term conditions specifically benefit from those targeted interventions of supported self-management, social prescribing, and personalized care and support planning. And people living with more complex physical and mental health needs, they benefit more specifically from personal health budgets, as well as the other elemental parts of the comprehensive model for personalized care. So why does this matter? So what? And isn't this happening anyways? Well, there's 3 main answers to the why. Why have personalized care? Why does this matter? People and patients want their preferences understood, respected, and acted upon. So there's a moral, ethical, and medical legal imperative to include people in the decisions about their care. And it's no longer enough in terms of tort law for us not to include people in how their care is designed. This was after a landmark ruling in the Montgomery versus Lanarkshire case, where in tort law, it's a medical legal requirement to share decisions with people about their care. And we must document this accordingly, including the options of doing nothing. Secondly, it's part of the definition of evidence-based healthcare. Clinicians' expertise plus the best external evidence and the person's values and preferences define the original definition in this Venn diagram of evidence-based medicine. And I don't mind as a clinician admitting that there was a point in my clinical career where I thought that pretty much if I was implementing nice guidance and offering that to a patient in their consultation, that what I was doing was evidence-based healthcare. And I don't mind admitting that I learned that it was not. And ultimately, a person's values and expectations are integral for us to deliver high-value care. So we're not delivering evidence-based healthcare if we're not delivering personalized care. And then reason number 3 of why the outcomes are better. There's 3 decades of evidence that say this. There's higher value of care, meaning the cost, quality over cost. The workforce is more satisfied. Patient outcomes are better. System outcomes are improved. There are financial savings and less litigation. So why not? You know, the why for personalized care and the business case for this is well understood. And yet there's a contrast between this why and the reality that we see in practice, but we must remember and hang on to the why. It's our ethical responsibility. It's part of the definition of evidence-based healthcare, and the outcomes are better. That is the why. That's the story of why for personalized care. But again, isn't this happening anyways? Here is some data. It's a busy slide, so I'll let your eyes orient over it, but some people context. We know in England that 5 in 10 people in England don't feel involved in decisions about their care and treatment. As illustrated in this graph below, this has also been the case for the last 10 years. This data comes from the CQC, the Care Quality Commission, who ask through patient-reported experience measures people's experience about their care. This specific data set asked about 65,000 people each year, so that you can add up the numbers from that, and it also was only specifically to the acute care setting. This data is also available in every other care setting and shows almost identical findings. The total of which is about 700,000 people are surveyed per annum, and the findings are similar to what's shown here. Secondly, we know that 1 in 7 people in England experience post-decision regret, and they regret decisions largely around more high risk or more complex care decisions, including cancer treatment or surgical decision making. And those decisions and the regret experienced from that come at a high cost. And if we improved shared decision making, that would reduce significantly. In addition, this isn't happening anyways, because we know that it's the root cause of a number of public inquiries, including the Patterson inquiry, the Ockenden report on maternity services, as well as a number of rising litigation cases. We know in England that there's been a sharp rise in clinical negligence simply due to ill-informed consent. Consent is not the same as shared decision making, but it is an elemental part of it prior to the consent process. And we know then, therefore, that shared decision making is not being deployed across England well because of all of these factors. 5 in 10 people aren't included in the decisions about their care and haven't done for 10 years. 1 in 7 people experience post-decision regret, and there's a sharp rise in litigation. 48 million is spent per annum and rising on ill-informed consent. And this is reversible harm that we can undo to the system, and irreversible and reversible cost that we can claim back. How do we do that? Is through shared decision making and personalized care being prioritized for our workforce in their skills and in the systems within which they work. Another piece of data to look at, again, thinking about how well is this implemented across England at the moment, this data shows that same patient-reported experience measure from the CQC, and it correlates it against the trusts in England who scored different organizational ratings in their own organization. So what this demonstrates is that the mean value between to what extent did the staff involved in your care include you in the decisions about care and treatment are more likely to be in organizations that perform outstanding on their overall organizational CQC rating. And there's a correlation between those who scored more low on that question of were you involved in the decisions about your care and treatment, and whether they were in the requires improvement category. So the evidence here is quite strong. Not only does asking this patient-reported experience measure matter, it's sensitive to personalized care. Providers who get this right are more likely to be outstanding, and that's an organizational culture piece. So HR and OD colleagues listening on this call will find this particularly interesting. Investing in what matters to you skills of your workforce means that there's a higher correlation of an overall CQC rating being outstanding. Let's look at some other data of England at the moment. So this is from the GP patient survey. It's the 2022 data. The next round of data should be coming out soon. The question of here is, how confident are you to manage issues arising from your condition? You can see the percentages stacked for confident and not confident, and each of the bars represents a sort of calendar year. And the trend from left to right is over time. You'll see this bit circled here is that we saw within 2022 a drop, not insignificant drop, in how many people felt confident to manage issues arising from their health and care. And this isn't a coincidence. This is often what we see after an international epidemic and pandemic, like the coronavirus, where we encouraged people to have very command and control messages about their care, disparate access to services, more chaotic presentations, and discoordinated, not joined up care. So this is the consequence of that. And why does that matter? We know that where people lack confidence to manage their health and care, they are 10 times higher utilizers of health and care services. So not only are we having a leaking system of high cost of litigation due to shared decision making, if we aren't helping people to feel confident to manage their health and care, they are more likely to overutilize the wider health and care system, which at a moment in time like now, where systems and services are under so much pressure, we simply can't afford to do. But the data is speaking to us. There are thousands of patients who contributed towards this data set, about just under 400,000. And they're telling us that actually there's a rising tide of demand, that we're all on top of an already significant burden in health and care system. We need to do something more. And the answer to this is health coaching approaches and personalized care. This data shows, this slide here shows that information about what can be improved. So again, as I mentioned, where people lack confidence to manage their health and care, see their GP 10 times more per year. But where people are health coached to feel more confident and knowledgeable and skillful about their health and care, this reduces and improves over time by about 40%. So again, personalized care makes a significant, not only individual healthcare improvement, but a population one as well, that helps to manage demand and capacity at a population level. Some other data to share is, have you had a conversation with your health and care professional from your GP practice to discuss what's important to you when managing your health and care? This is the really, the what matters to you question, but ask from the voices of patients. And this data is from the GP patient survey from 2022, and again is around 400,000 people surveyed in each financial year. So you can see here that there's a drop in the number of people who said yes in 2022, which is of concern. So people are no longer being asked what's important to them. If we're not asking what's important to them, it's back to the why. Why do we do this? The medical, ethical, medical, legal reasons to do this. It improves outcomes, and it is evidence-based medicine. So we're, it's starting to give us a signal that, are we going off here a little bit? So there's some focus that we need to think about as a national healthcare system, particularly here and now, as to what we do next with this. 2 more slides of data from me. This one is a really busy slide, so I'll let your eyes orient over it, but it's looking at the global burden of disease. This data is captured from the WHO, from health and care systems across the world, and is collated back into this data set. The global burden of disease, and specifically disability-adjusted life years. Disability-adjusted life years means life lived less well as a consequence from having a single clinical condition. This data is, of course, biased because we know that there's an increasing number of people who are living with more than one long-term condition, so it doesn't look at it in that lens, but it does offer us some helpful population health management insights as to the burden of that disease, or the impact of that on someone's quality of life. This data is from 2019, and it looks at the disability-adjusted life years. The blue blocks represent non-communicable diseases. The orangey red blocks represent infectious diseases or neonatal conditions, and the green boxes represent injuries or accidents in relation to this. The color, or the darkness of the color, is relevant, and the size of the box is relevant. So the size represents, the larger the box, the more the people in England who are affected by that single organ disease or single reason. And the darkness indicates how much that's changed over the last decade between 2019 and 1990. So it gives a longitudinal trend in England of how life is not lived well as a result of that condition, and is it changing? So quantity, bigger box, equals more people. Darkness of color equals it's worsening over the past several decades. So you'll start to see that non-communicable diseases makes up the majority of this, which means that life lived less well from a single organ disease is mostly due to non-communicable long-term conditions. There are some conditions that have large areas like IHD, ischemic heart disease, and then there's some like diabetes that are both large and dark in terms of their worsening. Drugs and alcohol worsening in terms of their darkness is significant, and it's worth us considering. What does this mean about the population of England? How does this inform the services that we provide? How does this involve the training that we provide for our staff to equip people, to support people to live their best lives? When actually we know that this, the burden of this disease not only contributes towards economic burden, that over healthcare utilization that we described from when people are lacking confidence to manage their health and care, and increases system pressures. This is really well evidenced. So this GBD data gives us some really useful insights to sort of helicopter back and look at the needs of our population. This is critical now, particularly again with the long-term workforce plan publication, which speaks about specific actions on the workforce to help our population thrive and people live their best lives. This slide is now looking at global burden of disease data, but from a different angle. So it's the same data set. It's in England. It's in 2019, but it's looking at the root causes for these conditions. And the blue again represents non-communicable diseases. It does break it down into some other colors, as you can see from the legend here. But what this broadly tells us is that life lived less well as a result of a single organ disease is largely due to behavioral, secondly to metabolic root factors, and thirdly environmental. Now this is really interesting because if we correlate this back with what we noticed in other slides, the rate of how people are being asked what matters to them is reducing. People's confidence to self-manage is reducing. And again, we know that that increases demand and over healthcare utilization. But the biggest root reason for life lived not well as a result of a single organ condition is behavioral. And that's really promising because behavioral root causes respond to certain evidence-based interventions. Broadly, health coaching and personalized care. So actually, the value of the whole workforce being highly skilled at health coaching approaches really helps to support this to reduce on a population level. How we do that together and what the long-term workforce plan describes for us, I think, is going to be the most exciting part of what we do next. But again, using this population health data, we can start to make sense of this. This dashboard is free. The data set is available on the link there, and you can drill down to place-based level in towns. So what we've described here is some variation from perhaps what we may have been thinking, how well embedded personalized care is from our expectations as citizens and also as workforce members and as HR and OD colleagues who might be joining and hearing this today. And this variation is no one's fault. It's not like a problem of clinicians being unwilling to learn or resistant to change, but rather actually a health and care ecosystem that has evolved to perpetuate that variation from expected standards. And we know that things like the model of house of care from year of care are essential to seeing some of that improve. So some of this is the how. How do we turn this picture and change that rising tide? And there's no one quick silver bullet for that, but this element does help massively. Health and care professionals being supported to partnership working and being skillful, a public that are prepared for an empowered conversation, organizational processes that help enable that from a system infrastructure point of view, EPR systems that talk to each other between hospitals and general practice, and commissioning that's effective and help support the outcomes of a population really do help make a difference to making this variation reduce over time. And so given the introduction of ICBs a year ago and the NHS 75 anniversary that we're experiencing now, it's extremely important for us to be proud of the achievements of the NHS, but also give us a little bit of realism about what it is we need to focus on over this next chapter. And now it's time to let those activities embed and the infrastructure embed. So how does personalized care help our workforce? We haven't really touched upon that, but we have talked about it from a population health point of view and where we're at in England now. So we'll talk about a few elements of this. So how does this ethos help our workforce? So we do know that there is a strong correlation between when a person, patient outcomes and staff survey results. So we do know that there's a very strong correlation, and that's well evidenced in NIHR publications over the last 2 decades and much work on that. Personalized care also aligns us clinicians to our purpose. I became a physiotherapist because I wanted to help people to live their best lives and to do whatever they wanted to do and achieve their goals. Actually, if I take a personalized care approach to health and care, it incidentally improves my job satisfaction as well as patient outcomes. So we start to see this quadruple aim start to manifest in practice in an organization that prioritizes personalized care as part of its messaging from an executive level. And guess what? If we do that, then actually we also achieve some of what's already described in the long-term workforce plan, specifically around working and training differently and flexible teams. Some other research about the benefits from an organizational development point of view are that actually an organization or culture that prioritizes person-centered care sees a reduction in burnout. Management skills that overcome that in practice, overcome bureaucracy, and opportunities for professional development and self-care. Again, really relevant messages to what's in the long-term workforce plan. So clinicians that experience an organizational culture that is, again, prioritizing a person-centered care approaches have less burnout, greater job satisfaction, reduced sick rates, greater retention, improved productivity as a secondary output from that, and an improved quality culture of quality. Again, linking back with that CQC finding that we talked about earlier. So actually, it's the link between personalized care and so what for the workforce is incredibly strong. And that is because we all come to work in our NHS because we want to help our people, we want to help our communities, and we want to help people to live their best lives. So an organizational culture from an executive point of view makes a massive difference, and we shouldn't underestimate this. And again, this comes back to the findings from CQC as well that I'd articulated earlier, of that correlation between being involved in decisions about your care and the overall organizational CQC rating. This is a compelling case for actually personalized care improves the OD of an organization and improves the quality of care as well. There are a number of other initiatives that are occurring at the moment in terms of the embedding of ICS infrastructure. And one of those is the findings from Claire Fuller's stocktake on transforming primary care, published last May. Systems across England, as they took their legal responsibilities of accountability and assurance from the Health and Care Bill, also at the same time were encouraged to think a little bit about integrated neighbourhood teams and think about place-based working and what does integrated neighbourhood teams look like. And we're mindful across England that systems and local areas are starting to understand what that looks like, or doing a lot of this anyways, but wanting to mature it even further. So how is personalized care and this infrastructure piece relevant to integrated neighbourhood teams? Actually, the skill mix of your workforce and one team across health, local authority, voluntary sector plays, and the skill mix of this and how many of them and how they're deployed is really relevant now. So again, back to the needs of the population that we talked about, the skill mix and the shape of your workforce and how they're deployed is very, very relevant. All of them being skillful in personalized care approaches, and this being really important here and now. There are 3 roles within the additional roles reimbursement scheme that are particularly thriving at the moment. They make up over 1/3 of the overall additional roles reimbursement scheme quantity of the overall 26,000 roles. And those roles are social prescribing link workers, care coordinators, and health and wellbeing coaches. These are non-registered workforce roles and working in non-clinical roles, again, through the additional roles reimbursement schemes in PCNs and primary care. And they have very specific superpowers as described in the infographic here on the left. They play critical roles in coordination of care, connecting people with community assets in the voluntary sector, working with people with complex social needs, helping coach people with low motivation to take control of their care, and a number of other areas that are invaluable to the multidisciplinary teams or MDTs of primary care. I'm delighted to say that from the long-term workforce plan last Friday, again, it was communicated the NHS England's intent to offer this perspective of potential expansion of these roles and what that quantity will look like. At the moment, there's about 2,000 care coordinators. The ambition rises to 12,000 by 2036. Health and wellbeing coaches up to 6,000 from the current 1,000 position that we're at roughly now. Social prescribing link workers are at about 3,000 from September. And again, we want to increase that up to 9,000 by 2036. So this intention in the long-term workforce plan to prioritize these incredibly valuable roles as part of primary care multidisciplinary teams in integrated neighborhood teams is not only important now, it's incredibly important for the future. And recognizing their place within the workforce makes a massive difference. So again, some actions to consider on this from a workforce planning point of view. Again, looking at the needs of the population, establishing that in terms of benchmarking and the approaches that are taken. Again, the long-term workforce plan speaks strongly of system-based skill workforce planning and how the staff are deployed. Reviewing that from a capacity and capability point of view and what the skills and the needs of the workforce should look like in terms of continuous professional development, as well as the unique superpowers of some specific roles and what that skill mix looks like, and then assessing that again against the outcomes of care. Again, it comes back to those board report developing workforce safeguard requirements that we know are so important in terms of assurance of are we meeting the needs of our population. So personalized care is a golden thread throughout this whole process. Make sure that when you're doing workforce planning that you analyze data on patient-reported experience alongside staff surveys. As I've mentioned, the correlation is strong, and actually there's some unique insights from that it would be very useful to triangulate when you're planning the shape of your workforce. Use your PREMS data when it's terms of looking at what that skill mix looks like, and make sure that investment in training in the skills of personalized care is not always put to the bottom of the pile. It supports staff well-being, it dramatically improves retention, and showcases executive commitment and action. So these are important areas for us to contemplate and celebrate at the moment of the 75th birthday of the NHS. There are some free e-learning products available through the Personalised Care Institute, which was also mentioned within the long-term workforce plan, including core skills on personalised care. And these are also available for face-to-face training through training hubs within system level. And there's a number of products free available on that, as well as the ability to commission face-to-face training within training hubs. The accreditation process is again quite strong for these three new roles that I mentioned earlier. Again, face-to-face and online training, including some high quality in-depth workshops to help these workforce roles be safe and effective in practice. NHS England also published workforce development frameworks earlier this year that give a full outline of the supervision requirements, the training requirements, and again, the Personalised Care Institute being a conduit for that and a host organization for that is also mentioned within the long-term workforce plan. There's some new innovative types of training, and I think that it'll be interesting to see how this gets showcased over the coming months. But one example that the Personalised Care Institute has sort of led the way on with Keele University is around virtual patients. This is micro skills training for the workforce, and it takes only about 10 minutes to complete. But what it does is it's a virtual patient or an avatar that allows you to have a virtual consultation with a virtual patient, and it allows you to sense check your skills, and the patient gives you feedback on how their experience of care was live within 10 minutes. So it's micro skills training. It will give you written and verbal feedback, and it's launched in a number of scenarios in 2023 and more to come over the coming time period. So this is a really important moment in time to shine the light on that, particularly in terms of the long-term workforce plan, describing so clearly that we need to train differently. This is one way to consider that. And again, it's free, it's accessible, and it takes 5 minutes. So thank you for listening to the time that we've had today now. What I've kind of covered has been, what is personalised care? What does it mean to me? What does it mean in policy? And so what? We've looked at the data together about what the patients of England are saying to us and where our baseline is now. And we're not quite where we should be in terms of the reality of people experiencing this continuously. We've also talked a bit about how this helps our workforce in terms of an OD element of this, including learning and development, culture, and helping these specific system problems of high over healthcare utilization and how this can be addressed so well with personalised care. So the what matters to you approach is extremely important, not just now, but for the future. The long-term workforce plan from NHS England outlines the strategy for the next 15 years. And again, these 4 themes are highly relevant, and personalised care is woven through all of those. So anyone who is a clinician today who's hearing these messages, be curious about your own practice, look at your own data, consider using the avatar to test your own skills, see what it shows. Anyone here who is in a HR or OD role or a leadership role, it's so important to prioritize person-centered care for the culture of your teams. Your CQC rating will improve as a result of it, as well as the fact that your staff will be more retained, more valued, or feel more valued, and it's very worth the prioritization of that in your work. So thank you for listening today. It's been wonderful to share time with you, and I hope you enjoy the rest of your conference.